We are going to be talking about whether the day of your embryo biopsy determines the quality of the embryo and your chances of miscarriage and live birth. I am your host, Dr. Rahi Victory. Welcome to Fertility, Fact or Fiction. So tonight we're going to be talking about this great study that's coming out that says day of trophectoderm biopsy and embryo quality are associated with outcomes following euploid embryo transfers. So let's just jump into this for a little bit. There's always a question pretty much on almost every show that we do asking if a day 5 or a day 6 embryo is better, and is it worse to have a day 6 embryo and so on. So let's kind of touch on that quickly. As your embryo progresses from being initially a fertilized egg with the sperm up into a day 3 embryo, which we count by the number of cells, and you're usually expecting about an 8 cell on day 3, it'll then transition over day 4 usually to what's called a morula. And then by day 5, you're hoping that you're at the blastocyst stage. Now, it really needs to be an expanded blastocyst for us to freeze them, at least in our program. And sometimes it takes a little longer up to day 6 for you to achieve that stage. Or in some cases, rarely, you can wait all the way out to day 7 to achieve the blastocyst stage. So we know with the day 7s that even if they're genetically normal, the chance of success is quite low, unfortunately. And there are studies that show that. We've actually reviewed that on the show a long time ago. I think it was like almost a year ago now. But what about the day 5s and the day 6s? Well, there are studies that say it makes absolutely no difference. And then there are studies that say that the day 5s are actually better. And so this has been kind of an ongoing question about which one is better, which one is worse. And we don't always know because in theory, based on a study we've reviewed and held near and dear to our hearts for a long time, if you have a day 6 embryo, you should really be getting 6 days of progesterone before transfer, and a day 5 embryo 5. And most of the transfer protocols in these studies used 5 days of progesterone. So it's really hard to know if you're getting the same outcomes. But in this particular problem, the other question is, did they genetically test the embryos to determine if they were normal or not before they actually went through the implantation? And that's really critical, because if you have not determined that they're normal, how can you really judge whether a day 5 or a day 6 is better? Because you don't know if you're comparing genetically normal embryos to genetically normal embryos, or maybe the day 5 was genetically normal and day 6 wasn't, or vice versa. So you really need a very specific study where they compare the day 5s, they compare the day 6s, they're only using genetically normal embryos, and they looked at the quality of the embryo as well, so that you really have a good comparison. So these guys did exactly that study. This is from Harvard, so I guess it's a little bit of a hopefully reliable place to do some research in. And it's coming out in the journal Assisted Reproduction and Genetics. So this is a good journal. I really like this journal, and I do turn to it. We've reviewed many of their articles on the show. So the study is just brand new. It was just accepted August 31st, actually. So it is very, very new. It's not out in full publication, but they have the preprint ready here. And essentially, they looked at 555 embryo transfers from 418 patients. And they only used euploid embryos, so everybody was tested. It is a retrospective study, so keep that in mind. They had the data and they looked back at what had happened, which is never as valuable as data where you decide, I want to study this, and then you start following patients moving forward, which is called prospective. So this is a retrospective study. But they did create a reasonably good set of criteria to look at things by. And because it's all in one center, you kind of have some standardization of the various elements that they put into their project. So we're going to go through it and talk about what they did. So retrospective study, as I mentioned, they used NGS, next generation sequencing, for the PGT, which is really important because that's the latest and greatest technology. And so it was all standardized, and this is a bit of a more reliable technology. And they were all single embryo transfers. So that's also really important because you need to compare apples to apples, and you don't want to compare a single day 5 to a double day 6 or vice versa. So all of these were single. It was all done at the Center for Infertility and Reproductive Surgery at Brigham and Women's Hospital in Boston. Embryos were always autologous, so they did not accept embryo donation or egg donation cycles or even sperm donation. They excluded people that had egg donors or in vitro maturation. They excluded people where their embryos were imported from another institution or anywhere they had to thaw the embryo and rebiopsy them and refreeze them and then re-thaw again. And they also excluded anywhere there was any manipulation of the embryos where, for example, they froze them right away after they were fertilized and then waited and then thawed them and grew them out to blastocyst. So reasonably tight grouping of patients so that the data could be as uniform as possible. Okay, so I'm going to start by showing you the first part of this that's important. Can you share that? We're good? Okay, so in this table, they compared demographics between the people that had the day 5 biopsies and the ones that had the day 6 biopsies. Everything was statistically not significantly different except the AMH. So the AMH in the day 5 group was 3.8, and keep in mind this is nanograms per mil. Those are actually pretty high AMH values versus 3 nanograms per mil in the day 6 group. That is statistically significant. It was actually quite significant, 0.002 in this study. And also it's clinically significant, because that's telling you you are dealing with a population of patients that actually have stronger ovaries. So could that reflect on the outcomes? Yes, they did adjust for it when they did their calculations, but it's always something you got to keep in the back of your mind. So important to be aware of. Okay, so I'll try and blow this up, but it's kind of hard. Maybe if I go this way, will it work for you?
Yeah, that's still good.
Okay, I'll expand that a bit more. Is that better?
Yeah.
Okay, so maybe I can move it up a bit too. Okay, so this is the clinical outcomes of just straight day 5 versus day 6. So this is not based on the quality of the embryo. They just lumped all of the day 5s versus all of the day 6s. So the implantation rate was not statistically significantly different, because that we talk about this all the time, that confidence interval crosses 1. So if I show this to you, you'll be able to kind of see it a little bit better. If you look at these numbers right here, you can see it's 0.8 over to 1.02. That means it's not statistically significantly different. What about the miscarriage rate? The miscarriage rate, same thing, the confidence interval crosses 1. So they didn't see a difference grossly comparing day 5 embryos to grossly comparing day 6 embryos. When they looked at ongoing pregnancy rate, again, they didn't see a difference because it just hit 1, although now it's starting to look like there may be a difference. But when you look at the live birth rate, you had a 20% lower live birth rate, or chance of a live birth rate, I should say, in the unadjusted, and it was 19% in the adjusted when you were comparing day 6 embryos to day 5. So in other words, someone that has a day 6 euploid genetically normal embryo versus someone that has a day 5 euploid genetically normal embryo, the person with the day 6 has a 19% lower chance of achieving a live birth with that embryo. So this is the first sign they noticed where they said, well, this may be kind of concerning. Now, again, you'll notice that that confidence interval hits 1. So strictly technically speaking, it was not statistically significant in the adjusted, but it kind of gave them the idea that maybe there is something to this. So then they started breaking it down by embryo quality. So we're going to take a look at that next. Okay, so first table here is right there. Can you see that? Okay, perfect. Okay, so they now scored their embryos good, fair, and poor. Now, they didn't biopsy embryos that were C or D grade, so I'm not quite sure what they considered good, fair, or poor, and I looked for a definition. It wasn't defined in the methods. So I'm not sure what their scoring system was. But assuming it's some kind of reasonable standardized system, when they looked at the implantation rate and they had poor quality embryos. So these would be like, you're either not so great BC or CC for our program, then or a CB, then they saw a 30% decrease in the implantation rate, only for the poor. When they looked at good and fair, there was no difference. When they looked at the miscarriage rate, they saw an almost 400% increase in your miscarriage rate from the good embryos to the fair embryos. In the unadjusted, and even in the adjusted, it's the same thing. So a huge difference in your miscarriage risk when you go down in the quality of the embryo, even when it's genetically normal. So this is very, very important data. When they looked at the poor, same sort of numbers, very, very substantial. It's like a 350%, 340% increase in the risk of miscarriage. So again, very robust numbers showing there is this huge increase in miscarriage rate when you compare it to the good category, which is the reference category. So good to fair, big increase in miscarriage rate. Good to poor, also a big increase in the miscarriage rate. Highly statistically significant. Ongoing pregnancy rate, when you compared the fair to good, no difference. But when you compared the poor to good, it's about a 33% decrease in ongoing pregnancy rate. When you looked at the live birth rate, interestingly, again, the good to fair did not have a difference. So your live birth rate was the same. Even though the miscarriage risks are higher, the overall live birth rate was the same. When they looked at it from good to poor, though, your live birth rate decreases by 30%. That's what that 0.7 you can see there means. So you had a significantly reduced chance of a live birth if the embryo quality or grading was poor compared to the embryo that is good. When they looked at this from the standpoint of breaking it down into individual grades per each category, it's a little bit hard to understand the way they've done it here, but I want to kind of highlight this one area because actually what was reassuring about this was that only one of them actually showed up positive, and it just crosses one again. So when they broke it down individually, looking at the clinical outcome and quality of embryos, when they mixed both things in together, so your day 5, and they looked at the quality and they blended it all together, looking at all the different comparison groups. So between the day 5 and the day 6, if you had good quality embryos, which is right here, in the unadjusted, there was a 31% decrease in live birth, but in the adjusted, it's just at 1. So we don't know if it's just at 1 because of the fact that they need more numbers, and maybe with a larger study, it would swing more towards the day 5, or because of the fact that there really is no significant association here. But I think overall, looking at their data, it does seem to suggest that there is probably a higher risk of miscarriage, and there is higher risk of failure, meaning no live birth, when you have a day 6 embryo compared to a day 5. And certainly the quality of the embryos, even when they're genetically normal, is important. This is really important to me because we just had someone overseas who wanted to send us their embryos, and we have all 3 being genetically normal, but 2 of them have very poor quality. And those are embryos we would not accept because you're looking at a much reduced chance of success. So these are the kinds of things that clinically we need to make decisions on, because we don't want people spending loads of money to move embryos from different places, or to, try and create new embryos or use old embryos, depending on whatever the scenario is, and waste money when the outcome may not be as robust. So this is a very, very important study. I do wish it was prospective. Hopefully someone will do this in a prospective format. Maybe these guys already are. And very, very much, hopefully, they'll get bigger, more robust numbers where we can actually determine for sure if this has a significant impact. But is it true that a day 5 is better than a day 6? It is for miscarriage, that's for sure. They've shown that very clearly. For live birth, it probably is, but there's no clear-cut evidence here because the numbers are so close to crossing 1 in almost every analysis that they did. So I want to say thanks for joining us for that part of the show. Appreciate you guys always. I hope that was useful. It's a little bit of a shorter article, but we always have so many questions. We thought we'd get started a little bit earlier with your questions tonight. So don't hesitate to ask any questions that you have. And for those of you that have day 6s, don't get disappointed. They still have a very good chance, but there may be differences. And if you have your day 5s or your day 6s, you should probably be going with your day 5s first. If you only have day 6s, do not go and make new embryos. These are all percentages. Yes, there was a 30% less chance, but that doesn't mean it's eliminated your chance. It just means the chances are lower. You still have a good chance with those embryos. I'm ready.
Hello, amazing VNT.
VNT. Oh, I like that. Yeah. We haven't had the VNT team. All right.
It's usually the TV team, but started with amazing.
They can't all get it right every time.
Yeah, that's right. Comes some slack. FET is tomorrow.
Oh, good.
And I developed a UTI over the weekend.
Oh.
Started Cipro on Sunday and will be taking it 2 times a day for 7 days. Can either the antibiotics or the UTI impact implantations?
Cipro is contraindicated in pregnancy, and I definitely would never recommend a transfer with an infection. So I would actually hit the brakes. Sorry. That's risky for you, and I would not recommend you continue. We don't use any of the fluoroquinolones in pregnancy because they're contraindicated, and Cipro is a fluoroquinolone. And on top of that, you're infected, which means your immune system is more active than it should be. So we would never support doing a transfer under those circumstances. I would stop if I were you.
Hey, Dr. V, I spoke with you on Instagram, asking for advice in my desperation after 3 failed FETs, worried about implantation failure.
Okay.
I found out on Sunday that I'm pregnant with our first tested embryo.
Oh, that's awesome. Congratulations. That's amazing.
Just by talking to you.
Just by talking to me. That's kind of cool. Yeah. There are a lot of people that kind of follow us online and then just do what we say and succeed. So we always do this show to just help you. It's not about having everybody come here. So yeah, that's amazing. Congratulations. Very, very happy for you. Wonderful. Yay.
I feel people really belittle stress in this entire process.
I think fertility programs undervalue or fail to address appropriately the stress that's caused. Yeah, for sure. Yeah. I mean, we had that whole article on sexual stress, and then there's just psychological, emotional stress. That's why when we set up our program, we created a whole division of our program dedicated to reducing stress and anxiety and dealing with the emotional, psychological, to some extent, spiritual, mental components of the journey, because it is stressful and it can be terrible and it can be devastating to you and to your relationship and to your partner and each other and even those around you. So yeah, for sure, it can be a really tough battle.
Doctor, it's my 5th IUI today.
Oh.
It's 12 days after IUI. I have lots of symptoms. I don't know if it's progesterone or pregnancy. Back pain and abdominal pain. Is pregnancy symptoms or periods?
There's no way to know. But I mean, I would just go get a preg test. If you're 12 days post IUI, you can get a preg test now and you'll know. So there's no way to answer that. Someone asked me that the other day, and I said, it kind of sounds like you're pregnant, and she was. So every once in a while we get it right, but there's no way to know if that's related to pregnancy or your period coming. So if it feels different from what your period normally is, then it's probably pregnancy. If it feels like what your period normally is, then it probably isn't, unfortunately.
Hi, guys.
Hey, guys.
Doc wants to put me on letrozole after 8 months of not falling pregnant.
Okay.
37 here.
Okay.
Happy to try treatment, but I don't want twins. How likely would these meds could cause twins if it works?
Letrozole. So if you have, first of all, we don't have a diagnosis because you haven't told us very much there, but if you have unexplained infertility, letrozole alone is useless. So don't use letrozole alone. Watch our fantastic video on unexplained infertility on YouTube. It's a very good video. It's very didactic. It goes through all the evidence. It reviews everybody's guidelines. It's got every single step of what you need to know about all the different options. So don't use just letrozole. It's a complete waste. With unexplained infertility, your chances of success in conceiving a pregnancy are from 3.1 to about 4.3%. Using letrozole, it's 3.7%. So it's right in the middle of that. It's useless. It's totally useless. Don't do it. In terms of your chance of twins with letrozole, let's say if you had PCOS or something like that, it's between 5 and 8%. So it's a pretty slim chance of ending up with twins, but there is a chance. So if you're desperate to avoid it, then obviously don't use letrozole or Clomid.
Hi, Dr. VNT! Exclamation mark.
Oh, there you go.
I took the exclamation mark for myself. One chaotic day, 5AA,
Okay.
and one no DNA found.
Okay.
Day 7, 5AA.
Okay.
My clinic has recommended rebiopsy with whatever I may get from my next egg retrieval. Thoughts on rebiopsy, relevant studies.
So it was the day.
Day 5,
The
5AA, and no DNA found. Day 7, 5AA as well.
Oh, so the day 5 has no DNA. They didn't get enough.
And no DNA found.
Oh. Yeah. So I'm not a big believer that it's okay to rebiopsy embryos. If they're 5AA, you're actually in good shape. So you could, because that's a very high quality embryo. And if any embryo is going to survive a thaw biopsy, refreeze, rethaw, it would be a 5AA. That's like an amazing embryo. But in general, we do try to avoid it. I'm not mortally opposed to it, but it's not great. From the standpoint of your day 7, I mean, day 7s, even when they're normal, they have a low chance. So I wouldn't poke and prod it. Just use it. The other part of this is the study we reviewed last week, which shows that when you have a low number of embryos, you actually reduce your chances doing the PGT. And apparently there are 2 studies. I haven't seen the other one, so I don't want to speak to it, but apparently there are 2 studies showing the same thing. So I'm not sure it's a great idea to do any PGT in your circumstance because the studies are showing that it's not beneficial. If you look at that article we reviewed last week, it was almost double the live birth rate when they didn't do the PGT. So I think the jury is still out on what to do with PGT in general, but it is definitely getting very confusing for the people that have low embryo yield, because the ones with low embryo yield apparently have even worse outcomes when they do the PGT. We automatically thought the opposite. We assumed, apparently incorrectly, that the patients that have the lower number of embryos probably have not as great egg quality, and therefore they're going to have a higher risk of having genetically abnormal embryos. And obviously age frequently plays a role. But the reality of that situation is that's actually not true. They're beginning to show in studies that when you biopsy those embryos, you actually do more harm than good, because the people that didn't get the biopsy had a higher chance of cumulatively ending up with a pregnancy because they had more embryos to try. And when you use them, some of these embryos self-correct, or they were never abnormal to begin with. So this is a complicated question, but in your circumstance, if you only ended up with 2 embryos, I would not do PGT on your next batch at all, or rebiopsy these ones, because the data is saying the opposite, that you should just go ahead and do your transfer. You'll actually have a better chance of success.
Dr. V, I'm 6 days PT, post-transfer.
Okay.
Right?
Yep.
And testing positive. Just wondering if I'm able to get my roots colored this week.
No, don't bleach my babies. I say that to all my patients. No dyeing your hair. That stuff is all chemical and toxic, and your scalp is literally one of the most absorbent parts of your body. Do not put stuff on your head. And don't worry about the hairstylists that tell you that they can keep the color off your roots, because that's total BS. They're washing your hair. You're washing your hair. All that chemical seeping into your scalp. Do not get your hair colored. You're going natural. Don't bleach my babies.
I like that.
Yeah, it's a good catch line, eh?
Yeah.
Don't bleach my babies. We should get t-shirts with that.
Oh, yeah. You know what? Good idea. Hi, Dr. VNT. Which one is better, frozen or fresh embryo for natural cycle?
Oh, no, I do a fresh. You don't need to do a frozen. Yeah, I would just go straight to your fresh. As long as your endometrium's good, you don't have endometriosis, I would go straight to a fresh. If you have endo, it's different, but no, I'd go straight to a fresh transfer.
What are the percentage of embryos survive to day 5 on natural cycle, one embryo male factor and 31 years old?
That's a great question. It would very much depend on which center you're using and how bad the male factor is and what your like habits are like. Are you someone that exercises? Are you fit? Is your egg quality really good? Are you taking all the supplements? Are you a smoker, drinker, drug user? Same thing for him. So all of that's important, but we actually usually get very high blastocyst formation with our natural cycle IVF. Usually, not always, but frequently we get very, very good outcomes. So I don't know that I have that data off the top of my head, but I would think it's probably somewhere about 60 to 70%, which is what we get for our blastocyst rate anyway. So it is quite good.
A lot of people on Instagram.
Excellent. Hello, Instagrammers. Thank you for following us there.
Your favorite
question. Did you like my nope videos? That's what I want to know. Throw up some likes or thumbs up. I want to know what you guys think of the nope videos. I do really like doing those because they're quite funny.
ERA. Is it really worth
it? For anyone, you know what? We need to redo an ERA video.
Do one all the time.
Like we actually need like because we did it as part of Fact or Fiction, but we need one of those separate like YouTube videos, right?
Yeah.
Okay, so the ERA test is useless. Do not do an ERA test. If you're working with a center that believes in doing the ERA test, they don't know what they're doing. It has been proven categorically to be useless. So please, please, please don't waste your money on an ERA test. iGenomics, the company that developed the ERA test, has sold the ERA test to another company now. So that's how bad it is. Do not do the ERA test. It is genuinely useless.
How long time wait to get done a embryo transfer do ERA? How long? I'm gonna paraphrase.
If you guys could see his face, you would understand why I'm laughing.
I'm gonna try and paraphrase. It's a bit, we have.
How long does it take to do an endometrial? An embryo transfer after you've had an ERA, or just after you've
something like that. Yeah, that's my guess.
Well, first of all, don't do an ERA, and then after it, you could do it the next month.
Yeah.
Your face, his facial expressions always crack me.
Yeah.
All right.
I'm CD3.
Cycle day 3.
Okay.
All right.
And haven't received my flowchart or meds list to order.
Okay.
What day should STEM start for a microdose Lupron flare protocol with letrozole? I'm wondering if I should wait until next month now.
Probably wait until next month now. If you're our patient, DM me, please, because that shouldn't have happened. But if you are somebody else's patient, I'd wait till next month.
Hi. I'm starting to prep for my FET and wanted to know when to start taking Florafem, vaginal probiotics. It's 6 pills. Thanks a million.
So we use it after 5 days of Zithromax. So you should have an antibiotic there, and then you should use that first and then start the Flora.
How long to wait between positive COVID test and FET?
2 months.
Can vitamin D deficiency cause a miscarriage?
Yes, that has been categorically shown. So ages and ages ago, one of our first I don't know about first, but one of the early Instagram posts was on the impact of vitamin D. Vitamin D does have a significant impact. There is some controversy in the literature about how much of an impact, but there is enough evidence there to support the fact that your pregnancy rates are lower and your miscarriage rates are higher. So make sure you're taking an adequate amount of vitamin D.
You're all-time high. I tried to take a picture of it.
Oh.
Dropped again.
All right.
And you're out. Oh, I always thought we should do a question about this. Hey, Dr. VNT, is pomegranate juice, Brazilian nuts, pineapple core, bone broth, and cat-cow exercise help with egg quality and implantation.
Okay, that's yoga.
Of course it is.
You know, when you're on your hands and your knees and you hunch your back and then you kind of go curve, that's cat-cow.
Yeah.
So
Oh, I get it.
yoga has been shown to be beneficial for IVF. There are actually a lot of studies that show that yoga is beneficial for IVF. So I do support doing yoga for IVF. In terms of all those other things, there is no evidence that any of those make a difference. So if it helps you feel better, then it'll probably help you. But there is no scientific evidence that supports that. So I can't address it because nobody knows.
People love the pomegranate discussion.
The pomegranate and the
Turmeric.
pineapple. Well, turmeric is different. Turmeric does have evidence, not for IVF, but
Yeah.
for endo.
Yeah, Dr. VNT, smiley face.
Smiley face. Yeah.
Can you do anything to prevent cysts? Can you do anything to continue with an IVF cycle if you have one?
Okay, so there are different kinds of cysts. So if you're talking about a functional or a follicular cyst, being on birth control will prevent those. If you are talking about a dermoid or an endometrioma, nothing will prevent those. So it depends on what kind of cyst you're talking about. If you already have one and you're starting an IVF cycle, if your estrogen level is elevated, you should not start because it'll screw up everything. If your estrogen level is not elevated, then it's probably not going to interfere, and you'd have to kind of figure out what kind of cyst it is. But as long as it's not going to physically interfere with your access to the eggs, you're fine. So let's go over a quick example. If you have a dermoid cyst, those are the gross ones that have hair and teeth and all that nasty stuff in it. If you have one of those and it's in front of where the, oh yeah, we get to draw. Let's draw it.
Yes.
Tarek loves it when we draw. All right. Do I need to reconnect
No,
to you?
you're still here.
Am I?
Mhm.
Okay. Well, let's get out of this guy and go to draw.
Can you draw that way as well?
Yeah.
Yeah.
You want me to do that?
Yeah.
Oh, look, we've
Perfect.
still got our picture from last time. Okay.
You're good.
I think so.
All right, I'll show you screen.
Yeah. Are we good there?
Get ready.
Okay, so if your ovary is here, oh, I didn't draw anything, did it? If your ovary is here,
Nice over.
there you go, nice ovary, eh? And our needle is usually coming this way. So if your cyst, we'll do the cyst in blue, is right here, and then you've got eggs in green over here, you can't get through to the eggs because everywhere you aim, that needle is going to have to go through the cyst. On the flip side, if your cyst is down here and your eggs are over here, well, then you're fine because you can miss getting the cyst and you can just go for all the eggs. So it does depend on what kind of cyst it is, because if it's a dermoid, if that blue guy is a dermoid, then you're in trouble, because if you pop a dermoid cyst, that's horrible. You're going to need emergency surgery. The pain is unbearable. And sorry for my thick pen for writing a dermoid, but anyway.
It's actually a great example, great drawing.
There you go.
Everyone learned a lot just now.
So yeah, so it depends on what's going on. You're going to stop sharing?
Yeah, I think
Okay.
so.
All right, fire.
Yeah. What do you think about agonist protocol, Ghana Peptil, for
Yep.
women over 40 years old?
An agonist protocol, long agonist protocol makes absolutely no sense. A microdose flare protocol, which is an agonist-based protocol, that makes a lot of sense, but not a long agonist protocol. That's kind of crazy. I would never do that. It's going to suppress you. And if you're over 40, you're likely making less eggs. So I don't see the value in doing that, because you're just going to have even fewer. Mostly throughout the whole world, there are very few people still doing agonist protocols. There are some. And if they have good success, more power to them. But very, very few people are doing agonist protocols still, the long agonist protocols. Some people, like me, use the microdose flare frequently, but I haven't used an agonist protocol for 10 years, I think. So it's been a long time.
a very good question this person asks.
Okay.
I hear a lot on TTC apps and forums. This should be our next video.
Okay.
Drink till you're pink, as in it's okay to drink until you get a positive preg test.
Oh my God.
What do you think about this? Is it in fact okay to drink till you're pink?
No, it is absolutely not okay. So alcohol shrinks the testicles, lowers testosterone levels, increases sperm DNA fragmentation, and has a 250% increase in your baby's risk of having a heart defect. And that's just on the guy side. On the female side, let's just talk about what alcohol is. Alcohol, ethyl alcohol, ethanol, that's in alcohol, is the exact same stuff that they put in all the hand sanitizers that we've all been using for the last several years to stave off COVID. Why did we use that hand sanitizer? Because it kills viruses and bacteria. How does it do that? By destroying tissue like viruses and bacteria. What do you think it's doing when you drink it? It's going directly into you and annihilating you from the inside out. So there is absolutely no drink to your pink. We got to do a post on that. I like that. Yeah. Brilliant. Find someone that says drink to your pink is good, and then we will. That's a great nope. That's a great nope. Yeah, that's a nope. You know what? Nope. Absolutely, you cannot drink to your pink. Nobody should be having any alcohol. Well, okay, personal opinion. Nobody should be drinking at all because it's poisonous and it's a class 1 carcinogen. It's actually known to cause 11 types of cancer. But if you're going to drink, please, please, please do not drink around the time that you are trying to conceive, because it is known to be terrible for your fertility. Do not drink at all. No.
Hi, Dr. P&T.
I can make those famous faces. Everybody comments on those. They're like your facial expressions.
Marvelous.
Yeah, they're good.
Can I have PCOS? That's the first part. I just had my A1C check.
Okay.
Since I had a chemical pregnancy, natural and failed transfer.
Okay.
My A1C was a bit high at 5.8, starting metformin again. Is insulin resistance?
I don't know enough information there to answer that. I mean, certainly you could. There's no way for me to answer that. Yeah, you'd have to get proper testing and assessment, and that's a whole history and physical examination. You need to see a doctor that can take care of you. Yeah.
Hey, Dr. B and Wingman T.
Wingman, I like that.
These are just great people.
You know what? I should get you a mug that says Wingman.
I love your show. It just keeps getting better and better.
There you go. Thank you for loving our show. We love doing it.
What is your opinion on good grade day 7 euploid embryos? Also, after how many days of progesterone should a day 7 embryo be transferred?
Yeah, that's a good
They just snuck it in there. Does a saline sonogram check for hydrosalpinx?
Okay, so a day 7 euploid embryo has a 15% chance of implantation and live birth. How many days? I'd probably say 6 days of progesterone, and then like 6 completed days of progesterone and then transfer. So you'd be transferring on the 7th day, which is what you should be doing with day 6 embryos. And then with regards to the outcome of a saline infusion sonohystogram, yes, it will show a hydrosalpinx for sure, if done properly.
I'm pregnant with a day 6 hatching, so yes, don't get discouraged.
Yes, thank you for sharing that. That's lovely. We have loads of success with day 6 embryos, so do not get discouraged. It happens all the time.
Hello, Dr. VNT. We've done standard IVF.
Okay.
Dual stem and natural cycle IVF with no luck.
Oh.
We have male factor and female DOR.
Okay.
Healthy young adults, 35, 36 years old.
Okay.
Looking forward, how do we go about egg donors at your clinic and also embryo donation?
Sure.
What is the process and how does it work? Is there a website you recommend or an agency?
So on our website, we have a listing of the majority of the agencies that we work with. There are 2 that we have to add that we have not added yet, but they're all there. You can see them. So we have that for surrogacy agencies. We have that for egg donor agencies. Your starting point is actually just a consultation with us. We will go through everything with you. We will discuss your whole history. And then once we've discussed your whole history, we can go through the options. If you want an egg donor, we have a whole division dedicated to that with multiple employees and a whole other team of people that help with guiding you through the donation process and working you through which agencies to use, who's got the donors that are best suited to you, what you're looking for, all of that. So we have a very large third-party program. I think we're probably the biggest in Canada right now. So we'd be more than happy to help you out. Embryo donation, we are not sort of rich with donated embryos yet, but there are some. So if you're interested in embryo donation, you just have to contact us. We'll go through the ones we have, and then we'll discuss, whether or not those are suitable for you.
Hey, doctor. I guess this is a question just for you.
Okay. Sorry, buddy.
Yeah, as they all are, but we pretend.
You want some Kleenex?
No, I'll manage this one. We've been trying for a baby for a year and a half. Periods are a bit off, and doctor has me on letrozole. At day 7 wants to do a sonogram.
Okay.
What's he doing that for?
To see if your eggs are growing. If it's just a normal sonogram, they want to see if you're growing any eggs and to see what your lining's doing as well.
Hi, Dr. B&T. Can a lesser cone biopsy affect implantation with transfer?
Lesser or LSIL? It should say LSIL. Does it say lesser? Laser. A laser cone biopsy.
Laser cone biopsy.
Okay, can that what?
Can that affect implantation with transfer? SIS and HSG all normal. I am 35, one child before LEAP surgery.
I wouldn't do it around the time of the embryo transfer, but as long as it's distant from when you're doing the transfer, no. The only concern would be how much scarring is there at your cervix and can they get through at the time of embryo transfer. So that would be one of the few instances where I would want to just make sure I can pass something through there. If they could do the SIS, then they can do an embryo transfer. So you should be fine.
Is there an age cutoff or sperm source that makes it harder to have a healthy embryo? Still dating and want to know if any particular age of man will be detrimental.
Yeah, so we actually have a video on that. I can probably find it on our YouTube. So we have a video of the, hang on, and I'll get there and then you can do it. www. So we have one on what's age got to do with it. Is that what it's called?
Yeah, there's one like that.
Right, in the men's section?
Mhm.
Yeah. Right?
The men's section.
Now we have a men's section. Okay, now you can share. So where is the men's section? Fertility for men, and then go over to right there. Men, this is for you. Male fertility, does age have an impact? So if you click on that, it'll go through the impact of age. But yes, the older a man gets, the worse the sperm quality. That is true, in particular in regards to DNA fragmentation. So that's important.
All right.
Yeah.
Hi, Dr. B&T. Super duper big smiley face after the T. I had a positive pregnancy test.
Okay. You stopped sharing, right?
Yeah.
Okay.
I had a positive pregnancy test prior to my second retrieval. Oh, a lot of numbers here.
I had a second what?
Retrieval.
Yeah.
Prior to my, I had a positive pregnancy test prior to my second retrieval.
Okay.
I am an anxious mess!
Okay.
Exclamation mark.
Okay.
Betas. You ready?
Yeah.
12 DPO 134.
Okay.
14 DPO 259.
Good.
18 DPO 1384.
Wait, so we went 12, 14.
18.
What were we? We were 2, and then we were how much on 18?
1384.
That's normal.
20 DPO, 2636, 2,636.
Okay.
And then 23 DPO, 5,577.
Why'd they do 3 days? That makes no sense. So she was 2,600 before that one, roughly.
2636, yeah.
Okay, 60% of 26 would be roughly 1812, so 1,400, rough ballpark. So 1,400 plus 26 would be 4,000. Yeah, that's all normal.
US will be at 7 weeks.
Ultrasound.
Concerning?
No, that sounds like it's going normally, and stop testing, for God's sakes. You don't need to test that many times. So yeah, that sounds normal. You need a minimum 60% rise. It's kind of abrupt that it dropped off, so that's a little unusual, but all you need is a 60% rise. And it does slow down eventually, guys. It's not forever 60% because it levels at about 100,000. So that could be very normal, and I would just wait and see what your results show.
Dr. VNT.
No exclamation mark.
No exclamation, no smiley.
I am sorry, buddy. Yeah.
No great team, no lucky to be here, nothing. Just straight question.
Yeah.
Sometimes I make myself laugh. What protocols do you recommend for our first FET? We have a limited number of embryos, so we want to give it our best shot. No previous losses. Thanks.
Vitamins, vitamin D, iron, your prenatal, omega-3s. Make sure you're using a letrozole protocol, proven now and very definitive to be better. We've been using it for years. They're just starting to tell everyone to do that. Use a progesterone in oil and vaginal progesterone. That's helpful as well. Take melatonin, also helpful. If you have only a few embryos, you may want to consider embryo glue and an HCG wash. Those can both be beneficial as well. Antibiotics and then probiotics. The probiotics are really important to get optimal uterine and vaginal microbiome established. Make sure your lining's thick enough and then go for it. Smooth embryo transfer. That's pretty much all you need if you don't have any previous failures.
When can we see Tarek? I was going to ask. Reveal Tarek. It's like they're beating the drum.
They're chanting for it.
Yeah, they're chanting.
We're kind of trying to keep him like the Stig from Top Gear. Like he never he never came out. So he always had the helmet on.
If they want the reveal,
yeah,
they gotta do a hell of a lot better than that. You know, let's just be honest.
Don't do that to me mid-drink. You know what? We should have Tarek on. Actually, there is one video in all the videos where Tarek goes into the screen. I realized that a while ago when I was looking for one. So it's a blooper reel. I know. So yeah, you know what? Why don't you guys put up lots of demand for seeing Tarek, and then you know what? It would probably be fun eventually. We just sit side by side, and then we could do it. Yeah. I'm just gonna laugh, but
some questions are hard to do with the camera on.
Your facial expressions are too funny. Okay.
Yeah. 10 minutes.
Yeah, no worries.
Boatload, eh?
Keep going.
I'm going. Hey, Dr. VNT, can you do anything to prevent? Oh, they did that cyst question.
Yeah.
4-year-old. Here we go.
Okay.
Hi, Dr. VNT.
Okay.
What is the process of getting embryos transferred to VRC?
So you have to have a consult. And then once you've had a consult, we need to see your embryo report. If they were made with autologous gametes, meaning your sperm and your partner's, your sperm and eggs together, then it's fine. We just need to see the quality of the embryos. If it involved a donor, we need to see the reports on the donor because they have to be Health Canada approved if they were made in Canada. If they're not, then we can take a look at what the embryos were like, where your STD screens are from, all that stuff, and then figure it out. As long as they meet our quality metrics, no problem. We're happy to move them here. Getting them shipped, we put you in touch with a company called Core Cryo. They literally go to the fertility center. They put it into a special tank. The tank gets put in this plastic hard shell, which honestly I think would survive nuclear holocaust. And then they put a special temperature alarm thing on it. And then they bring it to us directly. It's here usually within a couple hours.
Following my question about the long agonist protocol,
Yeah.
though, do you think it can work for women over 40 years old, AMH 0.5?
No. I answered that question already if you didn't catch it earlier, but the long protocol does not work. So for women that are older, it's the wrong protocol. So I would not do that if I were you. Antagonist or a microdose flare.
Hi, Dr. V. and Tarek.
And Tarek, there you go. Yeah, that's important. Keep it in there.
Not Dr. Victory, Tarek. You're this Dr. V at this point. This is good.
They've forgotten all about it.
This is a great question. Already starts wonderfully.
Yep.
How beneficial is to take minoxidil for women 41? No PCOS and an AMH of 3.2. Thank you so much.
Not beneficial if you don't have PCOS. There's no evidence that inositol is helpful in a non-PCOS population that I'm aware of. I'll happily look it up for you guys, but I've never seen anything on the non-PCOs benefiting from inositol. It's crazy.
It's good. It's good. Hi, Dr. V. Once you get the referral from my doctor, how long does it take to get the consult with you?
So we triage them. Sometimes we get the initial consult done with Dr. Mayrand, who works with me, just to get you in quicker. I do all of the follow-ups, but it's a little faster going through her. If you're more complicated, then they'll get you to me. Usually like a month or two, and then you're in.
I'm 31. Ken, is still beneficial to take ubiquitol before IVF. I don't have problems, but we have male factor.
Yeah, it's always beneficial to take coenzyme Q10. So whether it's ubiquinone or ubiquinol, it's always good. So yeah, I would take it. It's always a beneficial vitamin or supplement for IVF.
How common is cyst development while priming with birth control and Lupron?
What? If you're on Lupron, you shouldn't be on birth control. If you're priming, you should never prime with birth control. Lupron is never used for priming, so I don't know where that's going, but you should not be getting cysts at all on that combination, but you shouldn't be on that combination. By being on the birth control pill while on Lupron, you're effectively negating the Lupron. So basically you rendered the Lupron useless. So that protocol doesn't make any sense.
How common? Oh yeah. Hi, Dr. VNT.
Okay.
Can DHA delay your cycle? I've been taking it for 7 weeks and my cycle has been delayed weeks. Could DHA be responsible?
Not normally. If it's severely raised your androgen levels, maybe. I've never had someone complain about that before, so that would be unusual. I would get your thyroid checked and your other hormones, and obviously do a pregnancy check. So that would be critical.
What qualifies a grade of embryos would you not accept? I want to transfer my embryos to VRC, but their grades are crap. Thumbs down.
Oh.
1 day 7 graded 1 cc, 2 day 6 is graded 4 cc, and 4 cb.
I'm so sorry, but we would not accept any of those embryos. Those are too low to meet our quality metrics. We don't even save those. So I'm very, very sorry about that. We would not be willing to accept those embryos. They have to be good enough to meet our quality metrics for us to feel confident that we're actually doing something for you by transferring them in. The chances of success with those embryos would be low enough that we would feel like we're kind of cheating you. And I don't do that. So I would stick with the center you're at. If you want me to kind of individually review your case, I will. We're happy to go over the consult, but anything in the C grades, we don't accept for transfer. Even if it's like an AC, we wouldn't accept it for transfer. So that's a much more difficult scenario. As you could see from the study we just reviewed, your miscarriage rates are 400% higher. That's not something we want for our patients. So we avoid that usually.
Hi, T and Dr. V. I've read you're super fertile for 3 months after miscarriage. Is this true? I figured that's the right place to stop, you know?
I was like, wow, there's a lot of information out there about us, apparently.
Yeah, that's a good place to stop.
Yeah, that was interesting.
It's been 3 months since my miscarriage.
Honey, I still love you. And the fact that you've been away for 2.5 weeks.
There you go. The internet is talking.
Okay, so are you super fertile for 2.5 to 3 months after a miscarriage?
Yeah.
You are no differently fertile after a miscarriage than you were before. You don't have to wait. That's been proven. But there is no increase in fertility after you've had a miscarriage either.
You're dying. They're all dying here. You see the amount of laughter faces.
Yeah. Tarek is quite fertile because he has a large family. I'm not quite as large in my family as Tarek is, but yeah.
About to wean off of PIO.
Okay.
Will be 12 weeks on Thursday.
Perfect.
Any advice for the anxiety of going off meds? I don't go back to my doc for another month afterwards.
Well, you can always go back to your doc. So just tell them you're anxious and you want to get checked, and that's fine. But anxiety, no. At this stage, the baby's placental tissue has taken over the role of producing the progesterone. You don't need it anymore. We do still keep our patients on some progesterone, but it's not for pregnancy support. It's because IVF patients have a higher risk of preterm labor, and we want to avoid the preterm labor. So we stop the PIO, but we continue the vaginal. So that might be an option for you. I bet you didn't know that one.
I'm constantly learning. I want to put up for the record, I am a student of Dr. Victor.
There you go.
100%. Although I do like to be Dr. T and, you know, I enjoy the whole bit, I am your student without a doubt. I just had a day 2 transfer for cell. And
okay.
In the past, I've had 3 or 5 day.
Okay.
What is the 2-day approach? When should I expect implantation given that it's a day 2? Thank you.
You'll probably get some attachments after day 3 and then full implantation after day 5 or 6. So I don't know what you mean by approach. I mean, I've never done that before. We don't do day 2s.
Can successful pregnancies lead to permanent changes to fertility menstrual cycles? I have PCOS, 3 successful IVF, back-to-back pregnancies. Thank you, Dr. V. LOL. Never have had regular periods in my entire life, 3 or 4 years max, and now appears to be getting monthly periods after my last pregnancy.
Oh, cool. Yeah, I mean, anything's possible. So your hormones can change, and your body can change. And so if your weight's gone down, if that was an issue, if you're eating healthier, if you're on all the supplements we put you on, thyroid changes, all of that stuff, it can make a difference and you can become regular. And age changes ovarian function quite a bit. My one warning would be make sure you're actually ovulating with those quote unquote regular periods, because you can have regular anovulatory bleeds. They're rare, but they do happen, and you need to be careful with those. And also, congratulations on your 3 babies, and you're welcome.
I wish there was closed captioning here. That's what she says.
Oh.
You want to see all the little banter we got going on? My little mumbles sometimes, they wish they hear, I guess. Can you remind me?
We got to get you mic'd. You got to.
I can do that. I just got to do it.
You got to do it.
Okay.
Yeah. I'm going to make you order it when we leave.
Can you remind me of that study you just referenced, the one with low embryo numbers and PGT testing?
It was last week on the show. Is it up already? Yeah, it is. It's already up. Here, I'll share that one with you guys too. How do you go back? Okay, that's weird. won't let me go back. I'm very confused right now. That's very weird. Okay, let's just put in Dr. Victory. My back button disappeared on my thing. Okay, so that was, let's just go to the home and then right there. So it's the third one in on the first line, fertility fact or fiction. And oh, we've got ads now. Sorry about the ads, guys. But if you watch this, it's called PGT testing and low embryo number. The main author is Dr. Casper, Bob Casper, and his group. And yeah, we've got a whole thing on it. So just watch that. And we talked about it and we went into detail and I show you all the pictures and stuff. So you should be able to see it there. Yeah. So PGT testing and low embryo number, it was out August 26th. So just a couple weeks ago. I thought that was last time. Wasn't that last time? I don't remember. Oh no, we had the sex one in between. Okay, fire away.
That's what I learned a lot. Thoughts about estrogen priming antagonist protocol.
If you guys had been around here after the last show to hear what we discussed in relation to alternative methods of quelling the immune system, you would have genuinely died laughing. So it was quite funny.
That should be like an after hours program. You know what I mean? Subscribers only. You know what I mean? This is full access.
What was the question?
Thoughts about estrogen priming antagonist protocol.
Yeah, estrogen priming has been proven to reduce your chances of success. Progesterone protocols are fine, but estrogen priming reduces your chances of live birth. We reviewed that a couple of weeks ago too. That was just another show. So don't estrogen prime. Where was that one? I don't know if I saw that one go up. Did that one go up yet?
When was it?
Like 2-3 weeks ago. I think that was the one I asked you about. Remember, I called you and I said there's one where we can't find it. I think that was the one.
I think it's coming up then today or tomorrow.
I don't know, but
because they got your top 10 and they got that one. So maybe they're just staggering.
Okay, go for it.
Thoughts about estrogen prime? Oh, sorry.
No.
Do you think steroids help with successful transfer?
Steroids alone have been studied multiple times and never shown to be of benefit. So we don't do steroids alone. I will do steroids with intralipids, steroids with tacrolimus or sirolimus, steroids with heparin and aspirin and Plaquenil and whatever else we're using, or subcutaneous IG, but I never do it just by itself. Alone, it has been proven to not be beneficial, so it's kind of useless to do that.
Does having a chemical pregnancy previously predispose you to having another in the next pregnancy?
Not if it's just once. No.
I just want to let you know that though the study covered on today's show and the answer to my question are discouraging, I appreciate the awareness and knowledge you bring to our community. Big heart.
Oh, thank you. Don't be discouraged. Yes, it looks like there may be a difference in outcomes, but it's only a percentage. So remember, if you have a 80% chance of success, let's say everything's really good, and you cut that down by 30%, that's a 24% decrease, which means you still have a 56% chance of success, which is damn good. Not that long ago, the chance of success with an IVF cycle was 30%. And that was in good responders with great embryos. We have come a very, very long way in terms of success rate. So to be double what we used to get just 5-10 years ago is still a really good number. So don't be discouraged. There is hope. And this is one study and it was retrospective. So I'm not convinced 100% by the numbers. And it's important data, but it needs to be expanded on for sure.
Dr. VNT, exclamation mark, 500 exclamation marks.
Oh, okay.
Oh, yeah.
It's
one of my fans.
Just for those of you that want your question noticed, the more exclamation marks and the more you highlight Tarek, the more likely you are to get your question. Yeah.
Is amoxicillin safe in early pregnancy?
That's a good question. So there is some data that came out a while back, large epidemiological data that said that antibiotic exposure in early pregnancy actually increases your miscarriage rate. Having said that, I'm not sure I believe it because it actually doesn't make any sense. So we don't know. There is some data to suggest that it's not super great, but on the flip side, having an infection is not great either. So it's probably the infection that's causing the problem, not the antibiotics.
Hi, Dr. V. My doctor put me on.
You still read that one, even though they didn't include you.
You know why? Because later on, they gave some hearts to T.
Oh, okay, all right.
They earned their question.
They earned their question.
Yeah, they earned their question. Hi, Dr. V.
Okay.
My doctor put me on Synthroid 50 mcg medication.
Yeah.
After my TSH came back 4.8, TPO 300, T3 and T4 are okay. What is pros and cons of this medication during pregnancy? Is it safe for a baby?
You need to be on Synthroid to keep your TSH less than 2.5 if your TSH is over 2.5. So it is 100% not just safe for baby, it's needed to optimize the neurodevelopmental outcomes of the baby.
I just had a day 2 transfer. Yeah, I see that.
Okay.
But there's some hearts with T's. So I'm contemplating what to do with them.
All right.
My fans, you know.
Okay, you're a fan.
They know how to get to me.
All right.
Yeah. I just had a day 2 transfer for cell.
Okay.
In the past.
No, she asked that. We asked that
we
one.
Did that?
Yeah.
Implantation?
Yeah.
Okay.
Yeah.
Okay.
See, now you're just looking for the hearts, man.
I got lost in the other.
You're not even reading the question.
No.
All right.
Here you go. Just for you, Dr. V.
Okay.
No hearts.
No hearts. No nothing. All right.
Raw question.
Yeah.
I was asking if higher sugar affects transfer and should I put hold on transfer? I have emailed your team back now in the weight. I have 6 PGT and 5-day 3 PCOS and male factor 2,700 million. Thanks.
Okay, that was kind of all over the place, but if you have high sugar levels, you should not do a transfer. It's a risk. If you're diabetic or you have elevated sugar and poor glucose control, there are risks for fetal brain and heart development. So do not do a transfer. That one's easy.
Please adopt my care from my clinic and adopt me into the victory practice.
Please what?
I said it says adopts, but probably abduct my care from my clinic. Just rip those things out of it.
You got to take a screenshot of that. We got to post that.
Just get me the hell out of here.
That is funny. Yeah, we would love to take you on. You just need a referral to us, and we will be happy to manage your.
It's been screenshotted. We'll censor it out.
That's good. I laughed pretty hard the other day when somebody said, what was it that they said? Oh, my doctor is sick of hearing, but Dr. Victory said. Yeah, that was good. But this one's even better. Yeah. Please abduct me from my fertility clinic. I like that.
We're not making this stuff up. Right? This is real. This is real. These are real comments from real people.
That's rich. I like that one.
908, last question.
Last question. Tarek's terminal question.
And to be fair, it doesn't say anything about me in it.
Okay. All right.
To stay neutral.
I appreciate your sacrifice, brother. Yeah.
Absolutely.
I know you. This is hard for you.
Yeah.
It's tough for you to swallow.
Yeah. Absolutely. So, Dr. V, after 6 IVF cycles, I finally have 1 PGTA normal embryo.
Wow.
What would you recommend to increase the success of a transfer with my only 1 embryo?
I would test everything. I would do the fertility testing. I would check your immune system and then follow our FET protocol. That's all I can say. If you're getting a conventional protocol, like here's your estrogen, here's your progesterone, that's the worst approach to it. So make sure whoever you're working with does it the right way. Use our FET protocol. We've put it on virtually every video. And I mentioned it even tonight, but don't use a conventional protocol. It won't work. Or at least I shouldn't say it won't work. It has the lowest chance of all the available options. So there's conventional, which is hormone replacement. There's natural and there's letrozole. Letrozole has the highest chance of success, so that's what I'd recommend.
There's one individual here from Manitoba.
Manitoba. Oh, let's
Sneak it
take
in.
Manitoba.
Yeah,
Come
that's what I
on.
said.
Yeah. How's Winterpeg?
Oh.
It's chilly out there. All right.
Hi, Dr. V&T. See, even from Manitoba, there's a
They
team.
got you, brother.
Yeah,
All right.
absolutely.
Yep.
I'm writing from Manitoba.
Okay.
I'm 38 years old.
Okay.
Subclinical hypothyroidism
Sure.
and heavy periods.
Okay.
But have been diagnosed with unexplained fertility.
Okay.
Should I bother with the IUI or go to IVF?
So watch our video on unexplained infertility on YouTube. I'm sure I can find that somewhere in here. And the reality with that question, and it's an excellent question, is that your chances are going to be very reasonable with, it's playing, so you can leave that in the background. So your chances of success with IUI are reasonable. How high? Pills and IUI with unexplained infertility is about an 8% chance of success. If you're doing the shots in IUI, you're getting as high as about 20%. If you are doing the IVF, you're going up as high as like 70, 80%. And then your other option is surgery. So there's 4 choices with unexplained. There is nothing wrong with starting with IUI. At 30, she said she was 38. 38, like if you can afford IVF or it's covered, I probably wouldn't do the IUI just because age is playing a significant role. And if you want more than one baby, that can kind of mess things up. But otherwise, unhesitatingly, I would go for it. Yeah, that's a great question. Okay, guys, we're way over. Thank you for a very entertaining and fun show. As always, they do seem to be getting funnier as we go. Huge round of applause for Tarek for reading questions that didn't say Auntie. And a very special thanks to my very lovely wife who has been taking care of my 2 younger children in Vancouver for 2.5 weeks. Honey, I miss you desperately, and I can't wait for you to come home. And big shout out for her. So go to @_Wendever. And everybody say we love you, Wendy, because that'll drive her extra nuts. She hates all the social media stuff. Have a great night, guys. Lots of love, and maybe next week we'll just do all questions. Okay. Yeah, and we've got another fertility coach that wants to jump back on with us in October, so we're going to set that up too. Okay, have a great night, everybody. Watch this video on unexplained infertility if you're struggling with unexplained infertility. It's a really good video. So hopefully you'll enjoy that. Take care, guys. Have a great night.